Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City. And I'm joined today by my co-host, Rachel Frank, a sports and shoulder surgeon at the University of Colorado in Denver. Rachel, how are you?
I'm doing outstanding, Pete. How are you tonight?
Oh, I'm doing good. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeon Society, the University of Utah, the University of Colorado, or the institutions of any of our guests. Okay, today we have an episode for you on a topic that is important to everyone, which is Cutibacterium acnes. And to give us the latest, I've invited on two national experts. The first from the Rothman Institute in Philadelphia, we have Surena Namdari. Surena, welcome to the podcast.
Thanks, Peter. Rachel, thanks for having me.
And then next from the University of Pennsylvania in Philadelphia, I have Gabe Horneff. Gabe, welcome to the podcast.
Thanks, Pete. Thanks, Pete and Rachel, for doing this. This podcast has been really good.
Well, first, I want to thank you both for coming on to discuss this topic. I know this isn't anyone's favorite, but it's super important for all of this because no matter how great of a surgeon you are, infections can always occur. Just so our listeners understand, these two experts certainly have lower than average infection rates, but they've done a great job of researching this subject. So let's start at the beginning with an understanding of the importance of this bacteria. So Gabe, fill us in on the basics. Why is this bacteria important for us?
So the basics of what we now consider C. acnes, which used to be formerly known as P. acnes, is that it's a bacteria that's a gram-positive rod that tends to live in the pilosebaceous glands, of which there's a higher concentration around the shoulder axilla region, especially in male patients, just because of the amount of hair follicles. And so the problem that we have as shoulder surgeons is obviously we're operating in an area where there's a high concentration of this bacteria. And then I think what becomes a problem for us from an infection standpoint is that it's not a typical infection that is easily recognized or easily treatable. And it tends to be one of these things that lingers on. And so we have a really difficult time understanding how to approach it.
Anything else you'd add, Surena? What else do we need to know kind of as a fundamental before we get started talking through the details?
Yeah, I mean, I think Gabe summarized that perfectly. I think, one of the main issues is that we have a really hard time getting rid of it. Typically we think about surgery as sterile, but certainly it's not. And because it lives in that deeper layer of the skin, once we incise the skin, it will be exposed into the wound and it can penetrate the deep layers. And so, it's something that's ubiquitous during surgery. And so because of that, we have to figure out how to deal with it in both primary cases and in revision surgery.
Let's ask you both prevention, because ideally we wouldn't deal with this at all if we could prevent it. So what are you both doing for prep? Let's take it through. If you do anything special in the pre-op holding area, what you do in the operating room, do you shave? If so, when? And then what kind of prep substances are you using? Serena, let's start with you.
So we do wipes in the preoperative holding area, dial antibacterial soap at home 3 nights before surgery. We shave the skin on top of the shoulder. We do not routinely shave the axilla. And then in the operating room, patients get their perioperative antibiotics. It's really important that they get that an hour before surgery or an hour before skin incision. And we try to time it so it's as close to skin incision as possible. We try to give ANSEF whenever possible because there's some literature to support that over some of the other antibiotics. And then we use IBAN or some sort of iodine-based dressing to seal off the skin. And during the prep, we use both chlorhexidine as well as hydrogen peroxide, and then also a ChloraPrep type of prep before incision. And so those are kind of the steps that we take. The hydrogen peroxide we do based on a study that we did and some data that Peter and Bob Tashjian have presented previously.
Gabe, how about you? Anything different? Anything this exact same?
I would say pretty much everything Surena mentioned is ideal for our patient population as well. Typically using ANSEF, I think the Mayo Group has really shown that really is the antibiotic of choice, even though it tends to be the joke. It's the only antibiotic we know as orthopedic surgeons. But and even in the instance of patients who, quote unquote, have an allergy to it, it still ends up being the best. I have started adding the hydrogen peroxide thanks to the work of Surena and Pete's groups respectively. I think the biggest point of that is that it's a cheap alternative. I think, as we dive into this conversation a little bit more, we're trying to find out other ways to reduce the colonization, but a lot of those things can end up being expensive or timely. Hydrogen peroxide is a nice, cheap alternative to do that. That doesn't have to be something where the patients have to be responsible for applying it well in advance. But yeah, otherwise it's pretty standard. The only other thing I would kind of throw into, I consider sort of part of the prep is that, using the first blade for skin incision and then immediately changing that blade to something else. I consider that part of the prep as the very beginning of the surgery, but otherwise everything else is the same.
I want to follow up. So it sounds like we're kind of hinting around benzoyl peroxide here. There's some literature that Mohit Galatra's given us to show that benzoyl peroxide is effective, but it has to be given for several days ahead of time. It sounds like neither of you are doing that currently. Tell me about that. Is that mostly because of the challenge logistically of getting that to the patients? Is that because of reactions you've had? Is that because you feel like the hydrogen peroxide is equally effective? What do you think, Gabe?
Yeah, I would say that probably the fact that you have to have the patients apply it themselves, usually 3 days in advance. Mohit Galotra's group obviously won the NEAR Award showing how effective it can be. And there's been some more, recent studies looking at the use of benzoyl peroxide and as well as with in combination of topical, clindamycin, and they all are effective. But the problem is that, asking a patient to be compliant with that, I have found that both in the pre and post-operative care of my patients, trying to keep things at a minimum for them reduces the chance of them doing anything to potentially harm themselves or run the risk of an infection. Even as much as we don't tell our patients to shave themselves before they get to the pre-op holding, we take care of all of that. So I think it's really just a matter of trying to keep it as simple as possible for the patient.
And what about you, Surena? Do you have similar reasons? Is it just that because it's such a logistical challenge for patients, or have you had problems with it?
No, I haven't had problems. I do think that the literature is pretty clear that benzoyl peroxide works better than hydrogen peroxide in terms of actually lowering the skin colonization of C. acnes during surgery. But at the same time, I think the compliance issue that Gabe mentioned is a real one. So I will occasionally use it if I have that patient that I consider to be really high risk. The young male patient maybe on testosterone who's got a kind of acne already on their back. That kind of patient, I will still consider using it. But for my routine arthroplasty patient, I don't, because honestly, it just takes a lot of time to order and to ensure that they're using it correctly. And I'm not sure at the end of the day that it adds that much in terms of lowering the risk of true infection.
So, Surena, you mentioned the young male patient, maybe the patient on testosterone supplementation. What are those the main risk factors? Are there other risk factors for this particular bacteria that you're worried about?
Yeah, I think it's a lot of authors have shown this. The group out of University of Washington with Rick Mattson and Jason Shu have done a lot of this work. But I think the patients that are most at risk for C. acnes are going to be that young male population, and they clearly have a higher bacterial burden of C. acnes on and in the dermal layer of the skin. So as a result, when you do their operations, they're going to have an increased risk that the deeper layers become inoculated with the bacteria. And so once those deeper layers are inoculated, then the question becomes what happens to those bacteria? And it's really one of several things. Either those bacteria will die and it'll be inconsequential. Those bacteria may remain just colonizers that are deep but inactive and not causing clinical problems, or it can lead to infection. And so, I feel like the more bacteria you have on the skin surface, the higher the likelihood that you're going to develop clinically significant deep infection.
What about you, Gabe? I think we've heard some mention about, the age, the gender, or I guess I should say the sex. We've heard some mention maybe about acne in the shoulder. If you see a patient who has a lot of acne on their face, do you worry? What are the risk factors you worry about for this particular bacteria?
Yeah, well, I think a lot of what we understand about C. acnes actually comes from the dermatology literature. There's been, different medications, whether it's antibiotic or different preparations to try to treat facial acne, and especially like acne vulgaris. And so I think all of those risk factors that Surena had mentioned obviously are a concern. The other thing that we looked at and had a couple presentations of was looking at some light therapy to try to treat this as well, using basically a metabolite that normally is kind of taken in by the C. acnes bacteria, and then sort of exposing that to a certain frequency of light, which causes an exothermic reaction and can cause it to lyse the bacteria. Unfortunately, there, especially around a surgical incision, becomes concern for reaction to the skin locally to that. And so, even though we did a study, we were a little bit concerned about the reaction and weren't really seeing much of a difference. I think the biggest thing that we run into is that right now our focus is so much on prevention because, we quote this rate of infection around 1%, so it's not a lot, and it'd be really hard to do some sort of trial following all these infection patients out. So the thought is, can we prevent it? But we just really haven't figured out a good way to do it.
Peter, I think one of the issues is that we diagnose infection very strongly based on our culture results. Like Gabe mentioned early on, C. acnes does not typically present with the systemic signs of infection or even the local signs of infection with purulence. And so we rely very heavily on our cultures. And so those young male patients are going to be more likely to have deep positive cultures because they're also more likely to have positive skin swabs and positive dermal cultures. So, it's true that we diagnose infection more commonly in young male patients, but that can also be a function of the fact that we're relying so heavily on our culture results.
Yeah, and I think that's a huge point because, everybody on this phone call who works in healthcare, I'm sure if we, swabbed our noses, we all have some sort of strain of MRSA inside our body just because, we work in a healthcare setting. And obviously, a lot of times we swab our patients for that as well. But clearly, we're not having some sort of infection. And the question then also becomes, is it an infection if your body's not really having a reaction to it, right? So people can be colonized in their urinary tract and their GI tract with all sorts of bacteria that really isn't causing any sort of host response. And we just kind of say, okay, well, you're colonized, but it's not a big deal. It really becomes tricky with these C. acnes infections where even the quote unquote infection isn't some fulminant thing that's, pouring out pus or making the shoulder red and hot. So it really is tricky.
Yeah, I think this is a hugely important point, and I think this is really the crux of the issue with the bacteria is if we find a positive culture, is that positive culture found because the patient has an infection, or is it a contaminant, or is it found because the patient is colonized with this bacteria? So I think that this is the question that if I could put it at the heart of this issue that I want to ask both of you is, when someone comes back with a positive culture, how do you know that it's real? What aspects of the culture are using? What aspects is it all based on the concomitant clinical situation? Are you running special tests on the bacteria? Are there other factors? What are the factors you're using, Gabe, to try and tease this out? Because I find this so hard.
Yeah, it's as I mentioned before, it's really tricky, especially in orthopedics and in medicine, we like to group things together. So we like to say that, if all patients show up with symptom Y, then, their treatment should be X. And the problem is I think with C. acnes and so much of it, the markers that we depend on for normal infections not becoming positive, and the patients come in with these sort of questionable complaints, oh, it's a little bit stiff, it's a little bit painful. You really start to stare at your x-rays and you start to wonder, I don't know, is it slightly overstuffed? Am I overanalyzing the x-ray? It looked pretty good at my first post-op. And so I find that with each one of these patients, I tend to order the same labs that we would for any sort of infection. Not that I necessarily think it's going to show me something, but definitely to rule out something worse. And then I really treat it on an individual basis, kind of based on, the patient, who they are, what's their gender, what's their age group, do they have the risk factors for C. acnes? what has been their chief complaint? How long have they been dealing with this from their, index of their surgery? And if I get cultures that come back positive, I'll take 5 cultures. And, I tend to say if there's a majority of cultures that come back positive, then I will treat them with some sort of antibiotics. But I have to say that I find it to be much more of an individualized approach than I would say approaching someone with a certain size rotator cuff tear or a certain defect of the glenoid on a primary arthroplasty.
I want to follow up on this a little bit more. And Surena, let me ask you, I think nowadays, people, residents in particular, they're trained for painful shoulder, but also other joints now post-op. If you're going to aspirate or even go to the OR to take a tissue biopsy, et cetera, hold the cultures for 3 weeks, hold them and see what grows. And then if you get C. acnes, treat it as appropriate. And I think a lot of times we see painful, unfortunately, and maybe it's just more in my practice, but we see patients who continue to have some pain after their surgery, be it a cuff repair, an arthroplasty, and we can't objectively find a reason why. Their components look good or the MRI looks good if it's a cuff or whatever it might be. And so we get some labs and we know that this is pretty indolent, so we don't see, really striking abnormal labs. And then ultimately we get an aspiration or a tissue biopsy, and lo and behold, we have bacteria. Do we blame the painful post-op shoulder on that? Or like Pete says, is this just a contaminant that happens to be there?
Yeah, I think that's kind of the crux of the question. I think what we know is that positive preoperative aspirations have a very high positive predictive value for getting that bacteria again cultured when you take tissue during surgery. Positive from pre-revision biopsy, arthroscopic, similarly has a very high positive predictive value that you'll again get those bacteria. But then, like you point out, the question becomes, are those bacteria actually the source of the problem? And so, there's ways that you can evaluate those bacteria. Those methods are not available at every institution. The group at University of Washington, the group in Buffalo, they try to evaluate whether the C. acnes are hemolytic or not. That may lead to testing that's more available at other institutions. As a result, right now, I think what most people can do at any institution is you can look at the time to positive culture. So if your cultures are flipping positive at 14 days, then that has a higher chance of not being a clinically, significant bacteria. We don't hold for 3 weeks. We hold for 14 days. But there's data from Joe Ionati and others that if you're getting positive cultures that flip after 8 days or so, they're likely not clinically significant. So you can look at time to positivity. And then you can look at semi-quantitative scoring. So depending on how the cultures are read, they'll read them as, broth-only growth, very rare growth, medium growth, or, moderate growth or high growth. And so you can use that information clinically. If you have 5 cultures and 4 of them are, heavy growth of C. acnes, and they're flip positive at 4 days, you can feel pretty confident that that's real. But if you have, 2 cultures positive out of 5, they flip at 13 days and it's broth only growth, then that's a case where you may choose not to treat that patient aggressively.
All right, let me ask you guys about some other things, pearls that you may do for prevention. And we're going to get into treatment in a little bit, but for prevention, is there anything else intraoperatively or postoperatively that either of you do to help prevent infection? We're talking, do you do special irrigation washes, betadine washes? Is there any sort of special dressing that you use that's, marketed to be low for bacterial or viral growth? Do you give any extra antibiotics, either IV if they're staying overnight, or even if they're going home? Do you give an extra dose of IV Ancef in the PACU? Do you give oral antibiotics for home? And if so, which ones and for how long? Gabe, let's start with you. Any pearls that you do to try to, routinely for say primary patients with baseline risk factors?
Yeah. So again, I think for my standard, elderly female patient who doesn't have the risk factors, I wouldn't really do anything necessarily special. But for the patient who is more, fitting the category of someone you're worried about, I do, if it's an arthroplasty case, I will put vancomycin powder in the wound. Not that I necessarily feel that helps with C. acnes, but I do think the evidence shows it helps with infection overall. I will wash out with anywhere between 3 to 6 liters. I don't typically do a betadine wash. I do use the betadine, impregnated ioban for all my cases, unless there's, a risk for allergy. If it's a revision case and there's low concern for infection, meaning the cultures don't necessarily come back positive, all my revision cases I will put on 2 weeks of oral antibiotics, usually doxycycline or some sort of equivalent, just to prevent any chance of infection. But beyond that, I don't think there's really anything special other than, the wound coverage that I use is what I learned from Surena, what he brought over from WashU. I keep a multi-layered closure, absorbable suture, use dermal glue, clear Tegaderm dressing, waterproof. Try to make it as minimally bothersome for the patient so that they don't have to do anything with it. And I think that just increases the chance of compliance and doesn't, put them at any risk of potentially contaminating their incision by doing dressing changes or futzing around with it.
Surena, how about you? Anything different, anything additional, or exactly the same?
Yeah, I mean, I think that one of the main factors that is in our control when we do surgery is the speed at which we do the operation and the efficiency with which we get through the case. So, we know the Jason Chu's group has shown that the amount of C. acnes is essentially half its pre-prep level within an hour of surgery. So, the faster we move during an operation and the more efficiently we move during surgery, we lower the amount of bacteria that are in our wound. I do believe that as soon as we make skin incision, we kind of populate the field with C. acnes. And so I do use a betadine solution. And there is some data that out of Switzerland that shows that if you use a betadine solution after skin incision, that you have a lower deep positive culture rate. And I irrigate every case, primary cases, with a full 3 liters of saline. So, the solution to pollution is dilution. I use Vanc powder only in what I would consider to be high-risk cases, revision cases, immunocompromised patients. And I try to minimize the antibiotics. So I don't give patients routinely, extended courses of antibiotics. I don't put antibiotics in the irrigation solution. I do worry about antimicrobial resistance. I do worry about altering the microbiome. One of the things that we know in the shoulder is that we actually have low rates of MRSA infection in the shoulder and staph infection. And there is some in vitro data that some of that may be related to protective factors related to C. acnes, that prevent the overgrowth of more aggressive microorganisms. So I do worry a little bit about altering the kind of normal habitat of the shoulder with antibiotics.
So those are phenomenal prevention trips. Let's talk about, we've hinted a little bit about the difficulty in diagnosis. Let's talk about the painful arthroplasty. So you have a patient in your clinic. This is the patient, Gabe, you're talking about where you're scrutinizing the x-rays. You think the x-rays look okay. How are you evaluating that patient for C. acnes? What tests are you doing? Are you doing aspirations? Are you doing biopsies? Are you doing labs? Tell us, Surena, what is your workup for the painful arthroplasty to rule out C. acnes?
So I will try to aspirate that patient just because I know that commonly it's going to be negative or dry. But when it's positive, that has a high positive predictive value. So I think that's important information in that under 20% chance that it's positive. I will obtain standard infection labs, ESR, CRP, white blood cell count. We studied D-dimer as another test. It does not seem to have that much value. We tried to look at platelet-derived factors in serum, does not seem to have much value. So I still just get the routine preoperative infection labs. and then I will consider an arthroscopic biopsy in the setting where I really don't know what's going on. So that would be the case where I feel like the implants are well fixed and not oversized. There's no clear mechanical source for failure. And so that's the case that I'll do a scope biopsy, or the patient who I think that if I have a positive culture or positive cultures preoperatively, it might alter what I actually end up doing, whether that be a 2-stage because I may want to do a large bone graft or something else. So the 2 times that I'll scope are if I really don't know what's going on and everything looks well fixed, or if I think it'll alter my decision for a 2-stage versus a single stage.
What about you, Gabe? Anything else you'd add to that? I noticed interestingly there's no alpha defensin in there. There's no send out tests. Are you doing anything in addition to that?
No, so I agree wholeheartedly with Surena, and my threshold to do an arthroscopic biopsy is very similar. And again, it becomes that patient who's a head scratcher. I think, obviously Surena and his group has done a lot looking at these other markers, leukocyte esterase and the synovial fluid. It's not great. The sensitivity is kind of low. Specificity is fine, but it doesn't make it a great test. The alpha defensin, I think he's also looked at, which has been a little bit better, but even still, it's much more specific than it is sensitive. So it's sort of a rule out test that makes it difficult. And I think the key to understanding that for the audience is really goes back to this idea that, a lot of these markers that we use for normal infection are based on the host response. And so if you're not really getting that host response from the immune system, then, these markers are all going to be relatively low because your body's not reacting to it. Obviously I defer to Surena to talk about sort of the next gen sequencing, which he's done a lot with. But I think even that, the water is sort of muddy and obviously that's a thing where it's specific to your institution. I don't personally do any of that, but I know Surena's group has looked into that. So maybe you can talk a little bit more about that. But again, we rely so much on cultures, which in the terms of looking at infection is probably antiquated. It was one of the first things we ever did looking for infection in medicine. And it still, unfortunately, tends to be the only thing we rely on with C. acnes.
All right, guys, let's ask you about something that makes us all cringe. And hypothetically speaking, because I know you've never had one of these, but let's say, just hypothetically speaking, that you have a chronically infected prosthesis, a reverse, an anatomic. What are you doing? How are you handling this? It's chronic. They're not acutely sick. Are we doing a single stage revision, a staged revision? Surena, let's start with you.
So I think for me, it depends on the clinical presentation. So if somebody is presenting, and sometimes C. acnes will present more aggressively than we're taught, especially in the chronic situation. You will see occasionally a sinus tract. You will sometimes see purulence. And so if I see things like sinus tract or purulence, then for me, that's a 2-stage revision regardless of the organism. So that's a explantation, debridement, antibiotic spacer, treat for 6 weeks with antibiotics, antibiotic holiday for another 6 weeks, and then come back. If it's it's somebody that I have suspicion for infection, but there is not significant clinical signs, there's no redness, there's no drainage, there's no purulence, then most of those cases for me are a single stage revision, again with a thorough debridement, mechanical debridement, and extensive irrigation with a lot of the things that we talked about in terms of preventing infection, and then a single stage.
Gabe, how about you? Anything different or exactly the same?
I agree. And if it looks grossly infected on patient presentation, even if I know it's C. acnes from cultures, I'm going to still treat it as if it was something like MRSA and really do a full 2-stage. Otherwise, I think Matson's group and others have shown that there's a lot of morbidity with 2-stage surgery. There's also really, the outcomes have been pretty good for single stage revision surgery in the setting of, not a gross infection. And so I would agree that, trying to give the patient one surgery to get them through it is fine. The only other argument I would make is that, if it was a patient where I wasn't necessarily worried about gross infection, but at the time of surgery, due to removal of hardware or whatnot, I'm left with a little less bone. I might just go ahead and do a spacer just to help myself get a new CT scan when it comes time to consider what I'm going to do for the revision. But otherwise, I have to agree with Surena. I think, there's a lot of morbidity with two-stage, and if you can avoid it, and look, even if they end up, having a recurrence of a very quiet C. acnes infection, you can follow that over time and maybe buy them a few more years rather than taking them through 2 surgeries. And who knows, maybe they'll outlive before that second quote unquote C. acnes infection becomes a problem for them.
I think it's a little bit difficult in the literature to reconcile single stage and 2-stage because, it's not apples to apples. When we look at the literature, the 2-stage literature is mainly looking at cases that are, obvious clinical presentation of infection. The single stage literature is mostly indolent bacteria that maybe either unexpected positive cultures or they didn't really, necessarily know definitively that they were infected prior to surgery. And most of those are C. acnes or coag-negative staph. And so we know that both of those have in the literature over a 90% of infection eradication. But the problem is that all we can say is that a 2-stage revision for virulent infection seems to be equivalent to a single-stage revision for indolent infection. And so that's kind of how I look at it when I think about treatment. I think we may end up with problems if you start extrapolating that data to say that you can treat virulent infection with single stage.
Certainly, it's interesting to hear the shift. I think 10 years ago, everyone was doing 2 stages all the time. And certainly there's been some shift in that, which, I could not agree more that the 2-stage can be a pretty morbid process for the patient. Let's move on from arthroplasty and talk about failed cuff cases. So this is an area I think things, if you as a listener thought things could not get murkier, things get even murkier. So let's say, Surena, you do a rotator cuff repair, you're happy with it, it fails. The patient comes back, you're thinking about doing a revision. Or maybe you're thinking about doing a lower trap transfer. Maybe you're thinking about doing a patch, you're thinking about doing something else. Do you think, is there a role for cultures in this patient at the time of revision? Is there a role for cultures before you go to revision? Are there situations in which you start to think about them in that setting or no?
It depends on if I did the original surgery or not. No, I'm just kidding. I think that for me, it depends on what the imaging looks like. If the MRI shows lysis or signs of anchor loosening or changes in the bone that concern me for osteomyelitis, then or strange complex fluid collection, then I will send cultures. If the X-rays show any signs of lysis in the tuberosity, then I'll send cultures. But we realize that our sutures are colonized when we do our cuff repairs. That's been shown multiple times. And so I don't go chasing after it in those particular situations because, even when I'm revising a cuff, we're doing it arthroscopically. We're pumping a lot of fluid through the shoulder, especially in a revision situation. So, I don't go chasing after C. acnes generally in revision cuff situations unless there's something radiographically that points me in that direction.
What about you, Gabe? And maybe you could also add, let's pretend there's a prior cuff repair and now you're thinking about doing a reverse. Is that a situation where you start to get more nervous? Should I be taking cultures at the time of my primary in case there is some bacteria hiding on those cultures, on those sutures?
Yeah, so, for a revision cuff surgery, I agree. Unless something shows up on imaging like MRI that looks grossly infected, I'm probably not going to make too much of a big deal out of it. I think the thing that I still struggle with, and actually I posed the question to you guys as well after I finished giving my answer, but now that we have all these new available allografts in our possession that we tend to use more often in revision surgeries, even though I might not necessarily do anything for a revision cuff repair, the idea of putting in a piece of allograft or, another large piece of foreign material that can certainly harbor the chance of more infection, I do struggle with that sometimes as to whether I should continue to do that. In terms of converting somebody with a failed cuff to a reverse, I think in those instances, like I mentioned before, I will definitely put them on antibiotics following that procedure if C. acnes at the time of culture come back positive. I don't know if I would necessarily do anything different. Like, I'm not going to put in a spacer and then go ahead and put in a reverse. I think I would convert them to a reverse, but I would do all the tricks that we talked about in part of our prep. I probably would put the patient on oral antibiotics for 2 weeks after and watch them closely. But again, I mean, I find that we're probably going to leave this series of this podcast today with more questions than answers. And it's not because we are not knowing what we're talking about in terms of not knowing the literature. I think we just don't know in terms of we haven't answered the questions that we want as a collective society yet.
Something I'd love to ask both of you guys. Do you have patients where they're just on antibiotics forever? Like that you just cannot get rid of this infection. They're not sick, but their shoulder's not perfect. And you've done a revision, maybe you've done 2 revisions, you've done a spacer, and this just continues to happen. And you just say, enough is enough. You're going to be on antibiotics forever. Is there ever a patient like that? Surena, how about you?
I definitely do. I can't say there are a lot of them, but I definitely have patients who have chronic, typically indolent infections, sometimes even with a sinus tract that intermittently will drain when they come off of their antibiotics, and then they'll go back on their antibiotics and the sinus will close. And in general, those patients are people who are kind of infirm, or they're not appropriate for surgery, or they have very well fixed cemented long stem implants that would be an absolute nightmare with incredible morbidity to take out. And so those are people that in conjunction with infectious disease, we've decided to treat with suppressive antibiotics. And so there are patients like that. There aren't many of them, but they certainly do exist, and I think it does have a role.
Gabe, same for your practice?
Yeah, I definitely have a few. Fortunately, it's not a lot unless they're going to see Surena and he's not telling me about them. But I also have a couple patients, honestly, in the elbow world as well, who we're just basically suppressing it. I think one of the most important things is with these patients, getting your infectious disease colleagues on board. They don't get too excited about it. I guess within the world of infectious disease, it's not as exciting for them, but I definitely have them continue to follow up with the patient. I'm happy to send them, notes and emails, just asking their thoughts. And, we do have a handful of people that they just say, keep on lifetime suppression, and they do fine.
Well, certainly not the goal, but I totally agree with Surena. There are some situations in which taking a pill once or twice a day for the rest of your life may be less morbid than what you would have to do to remove some components that are completely well fixed and fully cemented. This is an area that I think hopefully the listeners are hearing is rapidly changing. I mean, there's a lot that's changed even in the last 5 years about the way we understand and diagnose and treat these infections. What do you think the future holds from here? If you had to get out your crystal ball, Gabe, if we do this again in 5 years, what are we going to say has changed?
So I think prevention is still going to be the goal for our group to try to end up treating this. The idea of an ounce of prevention is worth a pound of cure. Infection rates, fortunately, for shoulder surgery are relatively low. And I think just doing whatever we can do, like we've done with just the whole sterilization process and how we approach surgery in general to try to reduce infection, will continue to evolve. Whether that's, a different antibiotic, a different chemical topical, light therapy, who knows? But I think that's the focus. I also, and I think you can kind of sense this when you come to our society meetings and everything, is even in my short time in practice, I feel like the fervor behind oh, C. acnes, we got to treat it. It's starting to die down. And I don't want to say that we're collectively just shrugging our shoulders, but I'm starting to think that we realize, this is something that's sort of ubiquitous. A lot of patients can do okay with it. And, maybe we're being a little too aggressive to treating it, and perhaps we need to sort of just kind of back down and realize that it's there. I know for some people that doesn't necessarily feel comfortable or sit well, especially when you start talking about the medical legal world and saying, well, there's something colonized in there, but you're not doing anything about it. But I wouldn't be surprised that if in another 5 years, this is something where we really don't even kind of raise an eyebrow to it.
What do you think, Surena?
I think there are two things that I think about when I look to the future of understanding C. acnes. And I think the first is something that we talked about early on in this podcast, which is which bacteria matter, which are clinically relevant or significant. And I think that right now we're looking at just positive, negative cultures. It's a very archaic way to diagnose infection. I think as we become better with developing and understanding molecular techniques, DNA-based or RNA-based techniques to identify bacteria and their subtypes, and then understanding what those subtypes mean in terms of how pathologic they are, I think that will go a long way in determining which C. acnes matter and which ones maybe don't matter. And then I think the second is equally important and somewhat ignored right now, and that's the host. We all can understand that there are some patients who can get inoculated with a bacteria and develop no systemic response to it. They don't get sick. There are others that can get inoculated with the bacteria and they can have fulminant aggressive infection. And so we don't have a good understanding of why some hosts react to bacteria or specific bacteria in a certain way that leads to pathology, whereas others, it becomes part of their normal. So I think understanding the host will also be a huge part of kind of understanding this problem.
I want to thank you both for coming on. I mean, this is, again, a difficult topic to discuss, and it's hugely valuable to hear from both of you what you're doing now and what you think is going to change. So I really appreciate both of your time. This has been great. You guys were awesome.
Thanks, guys. This was great. I appreciate it. Thanks for everything you guys do for the ASES. This podcast is terrific, and it really keeps me occupied during my commutes.
Yeah, thank you both very much for having me. Surena, thanks for doing this with me as well. I wholeheartedly agree. This is one of the best podcasts for what we do as shoulder and elbow surgeons. And, kudos to both of you for getting some, although maybe not today in myself, but getting some heavy hitters to discuss these topics and to really kind of shed some light on how our field is evolving.
I'll echo Pete and thank both of you so much. Both of you are heavy hitters, and that's exactly why you're on here. And again, we want to thank you for coming on to talk about probably a not so fun topic, but something that's absolutely necessary because, like so many things in shoulder surgery and elbow surgery, if you haven't seen it, it has certainly seen you. And I think we can all say that for shoulder infections. That is all the time we have for today's podcast. We want to thank our guests so much for coming in to talk about this difficult topic, very educational and very helpful. For all of our shoulder and elbow listeners out there, please don't forget to subscribe. And for Pete Chalmers, I'm Rachel Frank, and we'll see you next time.